Hello and welcome. My name is Dr. Patrick Gallus. I'm a board-certified emergency medicine physician, as well as founder and chief medical officer of Gallus Medical Detox Services. Through a small story, I'd like to make everybody aware of the pharmaceuticals' efforts to market physicians in general. I was a second-year resident at Texas A&M, and after leaving class one day, we all presented to our mailboxes. There was 18 residents in our program at the time, and each one of us had a box of 500 oxycodone tablets in our mailboxes, as well as a stack of cards that you could simply send in and get another additional 500 pills of oxycodone. So in that mailroom alone at Texas A&M, there was 9,000 opiate tablets. That's how aggressively they marketed us, and they were very successful in their efforts. Today I want to talk about three major epidemics that are going on in this country, that being opiates, methamphetamines, and the benzodiazepine epidemic. What I want to discuss particularly is that these epidemics are worse than we think that they are. They're very frustrating to take care of because we're not having any luck in the solutions we're coming up with. And also, it's important that we keep trying. So first of all, let's talk about the opiate epidemic. The media has caught on to this, and it's one of the reasons we don't hear much about methamphetamine or benzodiazepines. But people have to understand that 100 billion pills were produced in less than a decade. So how did this come to be? Well, early on when I was a resident at Texas A&M, Scott and White Hospital Systems, if you came in with a fractured arm, several things would happen. You would be placed in a bed, we would initiate an IV, you would be given some pain medicine, then we would take an x-ray of your fracture, we would determine how to reduce your fracture, give you additional medicine to make you go to sleep, reduce your fracture, place you in a splint, and place you in a sling and give you the opportunity to recover from the procedure. After you recover from the procedure, we would put you or give you a script for orthopedic referral, and we would write you a script for short-acting opiates, generally Vicodin, 5 milligrams to 7.5 milligrams a tablet, and you would be given a script for 12 to 15 tablets for acute pain, which by definition is less than 3 days. So was there anything wrong with the way we treated pain back in the late 90s? And I will tell you, it was absolutely perfect. It worked well. So where did we get into this situation, and how did the epidemic that we have concerning opiates come to be? Well, we assumed that because short-acting opiates did such a great job treating acute pain, that certainly long-acting opiates would be able to treat chronic pain just as effectively. Chronic pain, that being pain greater than 3 months, we used long-acting opiates, and our scripts from 12 to 15 suddenly grew to an average of 36. So another mistake that we made was who was prescribing for the pain, for chronic pain in particular. And it was virtually everybody. All physicians, nurse practitioners, PAs, dentists, anybody with a DEA license. So you ask, well, who should have been treating for chronic pain? And I'm not sure the answer to that, but I can tell you it wasn't everybody. So the 500 plus chronic pain patients that I've taken care of in my clinic, to get them off their opiates, they basically had the same story. They've had long-term use, most of them greater than 3 years of daily use of long-acting opiates. They've had a poor quality of life. They have very little interaction with their family and friends, and very few of them were employed in it by any means. So, and they also had a great fear of getting off their medicine because they were still in pain, and that was their only, they felt that that was their only relief. So when we went through the process, generally 5 to 7 days to get somebody off opiates, what we found was virtually to a person that their pain had reduced significantly just being off the medication. And what we deduced from this was that chronic pain, when treated on a daily basis with long-standing opiates like Oxycontin, simply made the receptors, pain receptors, more hyperactive. And during this, their pain actually became worse. So not only did they lose a significant quality of their life, but the pain that they were trying to treat was worse on the pain medicine than off it. So we knew that there was a significant problem throughout the country, and specifically in Arizona in approximately 2004, 2005. We came up with what we thought was a solution in 2008, which was the Arizona Initiative for Prescription Monitoring. And what this was primarily made to do was follow patient use. It monitored the physicians and their prescription writing habits. It monitored the pharmacies and saw what pills they were distributing, and it also monitored the patients to see who was getting all these opiates. It had some good outcomes and some bad outcomes. The bad outcomes we really didn't see coming. The good outcomes was we were trying to reduce supply, and it did that. The bad outcome was that it drove opiates, pills in particular, into the black market. So now a $5 prescription became almost overnight an issue where a pill would cost 80 cents to $1 per milligram, most oxycodone tablets being 30 milligrams, so you're looking at $25 to $30. A 6 to 8 pill problem or issue could cost $240 a day. When you have an opiate addiction, you need your opiates every day. You can't take a day off. So we had held people accountable, physicians, pharmacies, and the patients, but we created a problem where they could no longer afford their opiates. This was a perfect opening for the Mexican cartels to reintroduce heroin into the United States in large quantities. So now a $240 a day habit, oxycodone habit, suddenly became a $40 heroin habit per day. Still expensive, but much more doable. So when George Bush had contacted Vicente Fox of Mexico, they had a discussion about the war on drugs. President Bush asked Vicente what he planned on doing about the war on drugs from the Mexican side. Vicente's response was, "The war on drugs is over, you lost." And he was right. So where did all these pills go, or where did they come from? And interestingly enough, when we look back on who was actually supplying them, it was really family and friends, greater than 50%. Only roughly a third of these pills were coming from physicians and their prescription writing habits. So what was the cost, both in mortality and financially? And it's been extensive. Drug overdose is now the leading cause of death in the age less than 50. In 2017 alone, there were 61,000 overdose deaths due to opiates alone. And unfortunately, that's projected to increase to 85,000 by 2025. We had a projected death total since 1999 of 602,000 people. And I'll throw out another number at 6,000 or 611,000 people. That is the death of soldiers in World War I, World War II, the Korean conflict, and the Vietnam War combined. In 1990, we produced 4 tons of Vicodin per consumption. By 2009, that number was 39 tons. Oxycodone even had a steeper rise, being 3 tons in 1990 and extending to 77 tons by 2009. The financial costs, fiscally, we're looking at costs over a 4-year period from 2015 through 2018 of $641 billion. And in 2019 alone, we projected that to be $214 billion. We also had some trends concerning for the FDA, which monitors these issues. They started a program an aggressive program in 2012, and after 5 years of running their program, they admitted they had no positive results. So who was to blame for this issue, and how did we get to this point? Who were the drivers? First, we have to look at who manufactured the medicine. So we're looking at Big Pharma, or the pharmaceutical companies. 3 companies made 88% of all the opiates distributed in the United States. Purdue Pharma being the worst player out of that group. From 1993 to 94, Purdue Pharma had conducted a in-house study where they enrolled 133 patients into a non-malignant, non-end-of-life pain study using osteoarthritis patients. Of those, only 63 people could complete the entire test, and 82% stated that they were having issues with the medication. Despite this in-house study, Purdue Pharma had determined that their drug, Oxycontin, was both safe and effective for non-malignant pain, or just chronic pain. A few months after this in-house study was done, an email was constructed by their CEO stating that he wished to franchise Oxycontin and doctors, general practitioners in internal medicine, the general bulk of our healthcare providers, to make sure that their drug Oxycontin was the go-to drug. They thought by going into the chronic pain market and staying away from end-of-life issues, which is how they went through the FDA, that they could produce 68.7 million additional prescriptions per year. And they actually underestimated this number by several million prescriptions annually. And also a few short months later, they'd polled 500 healthcare workers and found that 76% of them, that their product, Oxycontin, was their go-to medicine for any issues related to pain concerning their patients. A brilliant marketing strategy. So, pharmacies who filled these medications. There was 190 scripts of opiates written and dispensed by pharmacies in 2017 alone. 6 companies distributed 75% of all the opiates, and 15% of U.S. pharmacies distributed half the pills from 2006 to 2012. The outliers in this group: Sheer Drug purchased 6.8 million pills. That was 96 tablets for every person in Albany, Kentucky, over a 6-year period. In 2012 alone, they purchased 1.4 million pills, or a 55% increase from 2006. Value Med Pharmacy of Painesville, Kentucky, purchased 20 million pills. From 2006 to 2012, they were a town of 4,000 people. And Boonesville Drug dispensed 86 pills per capita over a 5-year period, only to receive a $500 fine for failure to maintain records. They actually lost their pharmacy license, but only after their owner received his 8th DUI. In physicians, we weren't out of the loop. We had some of our own bad players in this process. Among them, Dr. Joel Smithers, 800 counts of illegally prescribing opiates. He prescribed 500,000 tablets in a 2-year period. He's presently serving a 40-year prison sentence for second-degree murder. Dr. Thomas Keller would routinely prescribe 300 tablets on one script. He's convicted of 3 counts of second-degree murder. Dr. Stephen Hansen was sentenced to life for overprescribing methadone, which led to the death of 4 people. And Dr. Singh of Southern California has been convicted of second-degree murder when she was linked to the death of at least 13 people under her care. They estimated that she made over $5 million in a 4-year period at $175 a script. And the users, we need to talk about them. As a society and a culture, specifically in the United States, we have a mentality that stresses that there's a pill for every problem, and this needs to go away. 70% of Americans take 1 prescription a day. 20% of Americans take over 5. So, and these epidemics are driven by the habits of the users. So, opiate abuse and withdrawal. Signs of opiate abuse: sweating, constricted pupils, shallow breathing, slurred speech, and chronic constipation. Complications of withdrawal are multiple, and I want to dispel a myth right now that people can't die withdrawing from opiates. They certainly can. It happens in our prison systems on a daily basis. So they experience severe dehydration, diarrhea and vomiting, leading to significant dehydration, thus leading to electrolyte abnormalities, and finally cardiac failure. We also see delirium, multiple abscess formations, and chemical pneumonia from our patients that smoke opiates. So I want to talk about real life and what really happens on the streets. And I want to bring up a specific August weekend in America. Call was made to EMS about 2 unresponsive males, 24 and 26. EMS had reported to a private home where they found 2 unresponsive males. They were both deemed to be viable. Resuscitative efforts had started at that time. They were brought to the emergency department. After 30 minutes, the 24-year-old male had succumbed to his overdose and was pronounced dead. The 26-year-old male, on the other hand, had been successfully resuscitated. He was in the emergency department for approximately 3 hours. He refused social services. He refused admission to the hospital or any other care and left the emergency department against medical advice. On Saturday, mid-afternoon, call was once again made to EMS concerning 3 unresponsive females, that being 19, 23, and 24 years old. They were presented to a private house. The 19 and 23-year-old were pronounced dead at the scene. The 24-year-old was brought to the emergency department. Resuscitative efforts over a period of 30 minutes were unsuccessful, and she died. Saturday evening, similar call was made to EMS. 18, 19-year-old male. They were both brought to the emergency department. Resuscitative efforts over 30 minutes were unsuccessful, and they were both pronounced dead in the emergency department. So I've talked about 7 people, and 6 people have already died, but actually 7 people died out of this group because the weekend's not over. Sunday evening, unresponsive 26-year-old Male was brought in the emergency department. Resuscitative efforts were unsuccessful after approximately 40 minutes, and he was pronounced dead. So this patient that came in Sunday night, you have to understand, was the same 26-year-old male that had been there Friday evening. So where did this happen? Was this in Chicago, Houston, Los Angeles, New York City? Actually, none of those places. This occurred in Prescott, Arizona, a town of 37,000 people. And the only reason I know this story is because I was there Friday night and Sunday. So if things weren't bad enough, in 2016, the Mexican cartel once again saw an opportunity to make money, and they introduced fentanyl in large quantities into this country and combined it with the heroin that they'd already been bringing in. So fentanyl is a synthetic opiate. It's very potent. It's 80 to 100 times more potent than heroin itself. It's easy to make, it's very cheap, and it's easily transportable into the United States. From this, we saw overdoses skyrocket virtually overnight. One dose of heroin now, when fentanyl is introduced, is vastly different from the next dose. So users have no idea how much opiates they're actually taking from injection to injection. So lessons we've learned from the opiate epidemic: it's worse than we thought, and it's still ongoing. Gaps in supply are quickly filled by the Mexican cartels. The economics are staggering, and we're not doing anything to stop the supply or the demand. So let's talk about our second epidemic, methamphetamine. For me, this was a biphasic epidemic. In other words, I've taken care of this twice in my career. The first time was in central Arizona, 2004, 2005, when it was a significant problem. And what we saw at that time was mom and pop operations, everybody working independently. We saw a product that was approximately 70% pure and cost roughly $12 to $15 a hit. 6.5% of the U.S. population is admitted to using methamphetamines. 1.2 million people admitted to using it last year alone. The economic impact, although not that of opiates, was $24 billion, still significant. And an alarming thing, the death rate has increased 7 times from my initial dealings with methamphetamine till now. Approximately 10,000 deaths per year last year alone. So what happened in Arizona and several other states is because methamphetamine in 2004, 2005 was caused so much chaos and so much economic damage, both to the emergency departments, police, fire, EMS, and even our court system, that the Arizona legislated mandatory sentences for both the production and the distribution of methamphetamine. Each carried a mandatory 10-year sentence. So most of the people that I dealt with in early 2000 are still in prison today. So the reemergence of methamphetamine. 2011 approximately, Mexican cartels using their established heroin routes and fentanyl routes into the Midwest and western part of the United States reintroduced methamphetamine in large quantities. Now Breaking Bad was a thing of the past, and this was actually a professional organization with producing methamphetamine that was 100% pure, and it was now $5 a hit. It's still extremely dangerous. There's no big pharma control over its quality. It's once again increased crime, inundated the emergency departments and social services. Seizures have been increasing to large quantities, sometimes up to 200 pounds. The Arizona border in particular, in 2005, has seized 31 pounds of methamphetamine. By 2017, we saw that number rise to 1,400 pounds. And it is a problem in the Midwest and on the West Coast, mostly due to the Mexican drug routes, which once again are very established. There's reportedly more methamphetamine overdoses in Portland, Oregon last year than heroin. So why haven't we heard about the methamphetamine epidemic? And the reason is simple, is that we can only tolerate so much bad news. And prior to the pandemic, opiate is all the media talked about, and we didn't really want to hear about anything else. So, we have focused as a country and through the media and through our legislatures on opiates. However, benzodiazepines is probably the next thing we're going to focus on as a country. Benzodiazepines have been around since the early 70s. They were generally prescribed in treatment of anxiety or sleep disorders, but they've grown considerably over a period of several decades. The overdose rate has increased 830% from 1996 through 2017. Xanax is the #1 prescribed psychiatric medicine in the country, with over 50 million prescriptions written per year. Improper use of Xanax alone has increased ER visits by 125,000 patients annually. And I know that we've been talking about very large numbers, but I want to talk about the number 7. And even though it's a single-digit number, it's very concerning that 7% of all office visits to practitioners and healthcare providers in this country result in a benzodiazepine script being written. And that's pretty concerning. And again, these scripts are not coming from psychiatrists, they're coming from general practitioners. Benzodiazepines is also concerning. There's a lot of scrutiny under opiates through the mail system and online marketing. We're not really seeing this with benzodiazepine, and they're still easy to obtain through global online marketing. We're seeing the number of scripts starting to parallel that of opiates, which is another concerning factor, and could possibly even surpass opiates. We feel that due to the scrutiny from the DEA and the state agencies, physicians are concerned about their opiate writing habits, and they're simply switching to benzodiazepines. 190 million scripts written alone in 2017. So benzodiazepine abuse and withdrawal, signs of abuse: drowsiness, sweating, shallow breathing, slurred speech, and dizziness. Fairly similar to opiates in a lot of ways, actually. So the complications of withdrawal: major complication is seizure. If untreated, can certainly be life-threatening and protracted. We also see prolonged withdrawal symptoms that can linger for months to years if not tapered correctly, and this can lead to severe depression, suicide, relapse, and possibly addiction to other medications. So I want to talk about detox in general. And detox is an acute medical condition. I want to repeat that statement one more time so everybody understands. Detox is an acute medical condition. There's 3,500 deaths from licensed detox facilities alone per year. So it's a serious medical condition that should be treated as such. We've generally treated under the umbrella of psychiatry, and not that there's not a psychiatric component to what we do, there certainly is, but the initial treatment should be by medical professionals. And by that I mean physicians and nurses that have advanced critical care skills using advanced IV protocols in an environment that focuses solely on safety and has the ability for cardiac monitoring, at least in the initial phases of treatment. So, what have I observed over the last 9 years? I've observed our patients are sicker, they're more compromised, and more complicated than they were when we started 9 years ago. Most of that is due to polysubstance abuse, so patients taking multiple medications combined with alcohol, and increased comorbidities, which include hepatic failure, congestive heart failure, severe malnutrition, and pneumonia. So people often ask me about length of stay, so I'll go over this briefly. First of all, I want to tell people this is in the movies. When people are treated well under strict medical protocols, people are not lying around throwing up, sweating, and gravely ill with laying on a cold, dark concrete floor. So opiates in particular are 5 to 7 days, that being heroin approximately 5, Oxycontin being 7 if it's longer acting. Methadone, which is our longest acting opiate, takes us approximately 10 to 14 days. Benzodiazepines in general is a 7-day process. Methamphetamine is a 3-day process with mostly comfort measures. And alcohol can vary, depending on the severity, from 3 to 6 days. So let me talk briefly about acute medical detox and why we're an important component of solving this problem. And it really comes down to not only taking great care of people, but putting them in an environment where they can be hopeful, they feel safe and cared for, and we can determine where they go after our process is complete. Without that, what we've seen is people are asked to do too much, they're in too much pain, they're suffering too much, and they simply fail and go back to their drug of choice. And this happens almost every time that we see people placed in situations that they can't tolerate. So what have we learned? Or more specifically, I guess, what have I learned? I've learned that abrupt discontinuation of any drug is not an option. Patients will simply fail to be successful, and that's never our goal. Also, I've learned that people need to believe that they can be clean off drugs and alcohol should they choose to do so. And a lot of them don't believe that. We can't take the path of least resistance. That's how most of my patients get into trouble in the first place. And the risk of an unqualified program is your reputation, potentially your patient's life, and certainly their ability to succeed and be successful, be off drugs and or alcohol. And I also pose this question: is Big Pharma the solution to our problems? They're presently in a race to come up with medicines that are trying to help us out with the epidemic that they created. And I'm not sure if they should be in the conversation. We need to change our mental outlook. There's not a pill for every problem. Detox from any substance, whether that be in drugs and or alcohol, is simply a physiologic process. And if you follow the physiology and do it in a humane way, people are able to tolerate that process despite their fears and be successful. And for us, getting people off drugs and alcohol is either winning or losing, and we like to win. And we love to get people off other drugs, specifically illicit drugs or alcohol. So we're in interesting times right now. That's why we're all not together in San Diego, due to COVID-19. So I wanted a brief discussion because I think it's important. And I think that there's going to be some impact both in the substance use disorder patients as well as mental health in general. And I feel that there's already some ongoing evidence that both of these categories of patients and this population is being ignored. So when I talk to my patients concerning their drug or alcohol use, I ask them why they do this, why they shoot heroin. And the answers that I come up with are fairly consistent from patient to patient. And they list loneliness, isolation, past or recent trauma, lack of structure, a loss of community, drastic changes in routine, and economic instability. I feel like COVID-19 has accelerated each and every one of these processes in some way, and that we're going to have some drastic outcomes in our community in particular. So the forecast, there's no real numbers out right now, but the forecasts that we're looking at and we think are realistic is a 20-50% increase in overdoses, a significant increase in the overall suicide rate, which was climbing anyway, along with the overdose issue. A lot of us feel that between the overdoses and suicides, we could have fatalities that are certainly greater than were produced by COVID-19. Insufficient funds for treatment because money is heading in a different direction. We'll see and we've already seen a difficulty in accessing care in general, and I think that will continue for some time. We also fear that measurement and the actual numbers that are produced down the road will not reflect what actually happened concerning our patient population. That will only allow us to make the same mistake again should this occur. And we're really concerned and have already seen a fail first mentality, which is people aren't even trying to get off drugs or alcohol. We're living in uncertain times. And COVID-19 is going to test your abilities more than you ever imagined. Your students will soon be returning to campus, and you're going to need resources that you haven't used in the past. We have to look at the level of isolation that our students have been under and the overall stress to not only leaving campus early last fall, but returning to an environment that is uncertain. And that we always have to remember that they've lived under the same stress and conditions that we have. And I urge you to be overly prepared for their return. So in summary, these epidemics are worse than we think they are. They're extremely frustrating because we're pouring tons of resources into a problem that's only getting worse. And the most important thing is we can't quit because it's too important that we succeed. So we are in interesting times. That's where we're all not together. I don't have the opportunity to take questions, but I would like to give everybody some opportunity. If you have questions concerning my lecture today, please feel free to email me with any questions at gallus@gallusdetox.com. Thank you for your time.